Welcome to PRISM Rounds, the audio journal club for busy ICU, ED, pulmonary, critical care, and sleep medicine teams. I'm glad you're here. In each episode, we take one important study and work through the clinical question, design, key results, limitations, and bedside relevance, making new evidence easier to understand and apply in everyday practice. I originally started these episodes to support my own learning and now share them in the hope that they are useful to other clinicians and learners. This podcast is for educational purposes only and is not medical advice. Clinical decisions should always be made in the context of the individual patient and treating team. If you enjoy the episode, please like, follow, or subscribe to PRISM Rounds on Apple Podcasts, Spotify, or wherever you listen to podcasts. And please share it with a colleague who might enjoy it too. Thanks for listening. COVALENT is especially relevant to ICU physicians because it builds on the device trial. Device showed that video laryngoscopy improved first-pass success during emergency intubation of critically ill adults. COVALENT extends that signal into the operating room and goes a step further by comparing Macintosh style and hyperangulated video blades. Together, the studies suggest the conversation is moving beyond simply video versus direct, toward which video strategy works best, with which blade and adjuncts in which clinical setting.
Imagine you're standing in the operating room. The monitor is humming that steady, reassuring rhythm. The patient is deeply asleep, and you reach over to the airway tray.
The classic setup.
Right. And for, nearly 80 years, really, ever since Sir Robert Macintosh introduced his design back in the 1940s, the standard move was to grab a curved piece of metal and a small flashlight.
Yeah, the trusty old blade.
Exactly. You'd open the mouth, sweep the tongue, and look directly down the barrel of the human anatomy to find the vocal cords.
Which takes a lot of practice, by the way.
Oh, an incredible amount of muscle memory. But today, though, you are far more likely to grab a high-definition camera. Video laryngoscopy has aggressively taken over airway management.
It really has. Everywhere.
Yeah, if you're standing at the bedside of a crashing patient in the intensive care unit or the emergency department, that video screen is usually the absolute first thing you turn on. But here is the multi-million-dollar question we really need to answer today. In the highly controlled, perfectly optimized environment of the operating room, does routing a camera into the airway actually make you a better clinician? Or does it just make you feel safer?
That's the real debate right there.
Exactly. And if video laryngoscopy truly is superior, does the specific geometry of the blade you choose actually matter? Or is it just the presence of a screen that wins the day?
Well, that's what we're going to figure out.
Welcome to PRISM Rounds, Season 1, Episode 55. In today's deep dive, we are unpacking a massive, pragmatic, randomized trial that really forces us to look in the mirror and question everything we think we know about how we intubate.
It's a phenomenal data set. And frankly, it's exactly the kind of rigorous, skeptical evidence we desperately need right now.
Yeah.
Because when you're looking at a procedure like tracheal intubation, which, let's remember, is performed tens of millions of times a year globally, small percentage shifts in success or failure don't just exist in a spreadsheet.
Right. They have real-world consequences.
Massive downstream implications. For patient safety, for hospital equipment budgets, and especially for clinical training.
Definitely.
So my role today is to help you sift through the noise, because there is an enormous amount of statistical and methodological nuance buried in this paper.
Which you are very good at.
Thank you. We really have to look past the flashy headline numbers and interrogate what these investigators actually proved versus, what the device manufacturers' marketing departments might want you to believe.
And that is exactly why we're here. So our cornerstone for this duck dive is the COVALENT randomized clinical trial by Schmid and colleagues.
A huge undertaking.
Huge. And it's alongside a brilliantly revealing accompanying editorial by Desmet and Lascarou. Both of these were published in JAMA Network Open on August 3, 2026.
Fresh off the press.
Exactly. So our mission today is to unpack the COVALENT trial's findings, explore a vital and honestly kind of mind-blowing distinction between testing a physical piece of plastic versus testing a full clinical strategy. And ultimately, we want to translate what these operating room findings mean for you at the bedside. Whether you are an anesthesiologist doing elective cases or an intensivist managing utter chaos, this data matters.
Absolutely.
So let's start with the architecture of the trial itself. How did the COVALENT investigators actually build this thing?
Well, the trial design is where the true beauty of this study lies, honestly.
Okay, let's hear it.
So the COVALENT trial is a pragmatic, three-arm, multi-center randomized clinical trial.
3 arms. Got it.
Right. And it was conducted across 6 different academic and intermediate care centers in Germany and Austria over a 3-year period. So from March 2022 to February 2025.
That's a solid chunk of time.
Yeah. And they threw a super wide net. They actually screened nearly 30,000 patients.
Wait, 30,000?
30,000.
Wow.
But they ultimately randomized 2,532 adults.
Okay, we are definitely going to have to talk about that drop-off later.
Oh, we will. It's a huge point. But anyway, after a few dropouts and procedural shifts, we ended up with 2,423 patients included in what we call the modified intention to treat analysis.
Okay, let's pause right there because I want to make sure everyone listening really understands that term. Modified intention to treat?
Sure.
Because it gets thrown around in journal clubs constantly, and I feel like people just nod their heads. Why is it modified, and, why does that matter for a trial like this?
That's a great catch. So in a pure intention to treat analysis, you analyze every single patient exactly as they were randomized, right? No matter what happens afterward.
Even if the plan completely changes.
Exactly.
Yeah.
If they were randomized to direct laryngoscopy, but the surgery gets canceled 5 minutes later and they never get intubated at all, in a pure intention to treat, they still stay in that direct laryngoscopy data bucket.
Which just creates statistical noise.
Exactly. It waters down the data. So a modified intention to treat analysis allows researchers to make very strict, predefined exclusions after randomization.
Like what kind of exclusions?
Usually for administrative or logistical reasons, like the surgery being unexpectedly aborted before anesthesia even started, or maybe a patient withdrawing consent at the very last second.
Right.
It keeps the data clean without letting clinicians, cherry pick the results to make their device look better.
Right.
It essentially means we're looking at the patients who actually entered the arena and received an intubation attempt.
Okay, that makes perfect sense. Thank you for clarifying that.
Yeah.
Now, let's look at the 3 arms they randomized these patients into, because this mirrors the exact dilemma you face when you open your airway card.
It really does.
So, Group 1 was assigned to standard direct laryngoscopy. Group 2 was assigned to video laryngoscopy, but specifically using a Macintosh-style blade.
Right. So the same shape as the standard metal one, just with a camera.
Right. And then Group 3 was assigned to video laryngoscopy using a hyperangulated blade, that sharp, aggressively curved shape. And for you listening, we really need to appreciate the pragmatic nature of this design. Because, in a lot of specialized device trials, what we usually call explanatory trials, they take a handful of super users, right?
Oh, yeah. Key opinion leaders.
Exactly. They train them for 20 hours on a brand new proprietary gadget and then test it under perfect, pristine conditions. But COVALENT did not do that.
No, not at all. COVALENT is heavily pragmatic. The operators in this trial were just everyday practicing anesthesiologists and residents.
Just doing their normal shifts.
Right. They received absolutely no special trial-specific airway training prior to enrolling patients. They literally just showed up for work and used the tools they were randomized to use.
That is so much more applicable to the real world.
And even more importantly, multiple manufacturers were allowed.
Which is huge. Usually a trial like this is sponsored by one specific company trying to prove their plastic is better than the other guy's plastic.
Oh, constantly. But here, the trial included devices like the Storz CMEC, the GlideScope, the McGrath, and the HyniVision Pro.
Just a total mix.
Yeah. By allowing different brands based on whatever was locally available in that specific hospital's supply room, the investigators effectively made this a test of real-world clinical strategies.
Rather than like a perfectly controlled, highly funded marketing pitch for a single proprietary device.
Exactly.
I love that. Okay, so they randomize the patient, the clinician grabs the assigned blade, and then we have to measure success. The primary endpoint they were hunting for was successful tracheal intubation on the first attempt, what we colloquially call first pass success.
The holy grail of the airway.
Right. But I really love that they didn't just rely on the clinician's ego for this because, we've all been there. It wasn't just the anesthesiologist shouting, "I'm in, inflate the cuff."
Yeah, clinical judgment can be a little optimistic sometimes.
Very optimistic. The success had to be objectively confirmed by positive capnography.
Yes, and for anyone whose physiology is a bit rusty, capnography is the absolute gold standard here.
Let's do a quick refresher on that.
Sure. It's the continuous measurement of carbon dioxide in the exhaled breath. When you successfully place a tube through the vocal cords and into the trachea, the patient exhales carbon dioxide from their lungs, and you get this beautiful square waveform on your monitor.
The most reassuring shape in medicine.
Truly. But if you accidentally place that tube into the esophagus, which of course leads to the stomach, you get zero sustained carbon dioxide.
Right.
So by making positive capnography the mandatory confirmation step, the trial completely eliminated any subjective bias about whether the tube was actually in the right place.
Okay, before we rip into the headline results, we need to talk about the statistical gymnastics they used, because this wasn't just a simple race to the finish line, right? They used a hierarchical statistical strategy.
They did.
Can you explain that? Because I think a lot of readers honestly just skip the statistics section, but it fundamentally dictates how much we can actually trust the final percentages.
I don't blame anyone for skipping the stats section. It can be dense, but you're right, it's vital here. The investigators used a rigorous, predefined hierarchical testing model. Think of it like a high jump competition.
Okay, I like analogies.
Before you were even allowed to attempt a record-breaking 6-foot jump, the judges force you to prove you can clear a standard 5-foot bar.
Right.
In clinical trial terms, that 5-foot bar is called non-inferiority. First, the investigators had to mathematically prove that the new video devices were at least not worse than the standard direct laryngoscopy.
Okay, so just establishing a baseline of safety.
Exactly. And they set a non-inferiority margin of 5 percentage points.
Meaning, as long as the video laryngoscope didn't perform more than 5% worse than the old-school metal blade, it cleared the first hurdle.
Precisely. It balances patient safety with the statistical realities of trial sample sizes. And only after definitively clearing that non-inferiority hurdle were the investigators allowed to test for superiority, which is the 6-foot bar. It is a highly disciplined way to analyze the data. It ensures that researchers don't start loudly claiming superiority based on random statistical noise if the device isn't even reliably equivalent to the established standard of care.
I really love the high jump analogy. It makes so much sense. All right, let's look at who actually cleared the bar.
The fun part.
Yeah. So the data comes back. 2,500 patients later, who actually wins? For that primary outcome of first-pass success confirmed by capnography, traditional direct laryngoscopy achieved a success rate of 78.2%.
Okay.
Video laryngoscopy using a Macintosh-style blade came in at 82.9%. And finally, video laryngoscopy using a hyperangulated blade topped the list at 87.6%.
The statistical analysis here is really robust. Both of the video strategies confidently beat direct laryngoscopy.
So they both cleared the non-inferiority jump and the superiority jump.
Easily. And furthermore, the trial was specifically powered to compare the two video strategies against each other. And the hyperangulated video laryngoscopy proved to be statistically superior to the Macintosh-style video laryngoscopy.
Let's break those percentages down into what you'll actually see at the bedside. Because, you know, an 87% versus a 78% can feel a little bit abstract when you're just reading a paper.
Sure, if it helps to ground it.
When we compare the Macintosh-style video laryngoscopy to traditional direct laryngoscopy, we are looking at roughly a 5 percentage point absolute improvement.
Right.
And when we look at hyperangulated video laryngoscopy compared to direct laryngoscopy, that absolute improvement jumps to roughly 9 percentage points.
Which is a very noticeable difference in a high-volume setting.
It is. So we naturally want to look at the number needed to treat, or NNT.
The clinical bottom line.
Right. The data tells us you would need to use a Macintosh-style video laryngoscope on roughly 21.5 patients to achieve one additional first-pass success compared to just using a direct laryngoscope. Okay. For the hyperangulated blade, that NNT drops down to about 10.7.
Which, honestly, in the realm of clinical trials, an NNT of roughly 11 to prevent a procedural failure is quite impressive.
That sounds great, yeah.
It means for every 11 intubations you perform with a hyperangulated video blade instead of a standard direct laryngoscope, you save one patient from suffering through a failed first attempt and needing a second look.
Okay, hold on. I'm going to push back on that enthusiasm for a second.
I knew you would.
Let's really think about an NNT of 11. Yes, getting the tube in on the first try feels phenomenal. It's smooth, the team is relaxed, you feel like a hero.
It's a great feeling.
But an NNT of 11 also means that 10 out of 11 patients got a hyperangulated blade and saw absolutely zero added benefit compared to the old school $3 metal blade.
That's the flip side of the math, yes.
Right, and we are talking about overhauling entire hospital equipment supply chains for this. Plus, first pass success is ultimately a procedural endpoint. It's just a surrogate metric. Does avoiding a second attempt in a perfectly optimized, well-oxygenated, elective surgical patient actually translate to a better patient-centered outcome? Like, are we saving lives here, or are we just saving the anesthesiologist a few seconds of mild tachycardia?
That is exactly the critical skeptical lens we need to apply. It's a perfect transition into the secondary findings of the COVALENT trial.
Let's dig into those.
Because if you want to know whether this actually matters to the human being on the table, we have to look at what happens when we look beyond just getting the tube through the cords.
Right.
The secondary data paints a highly detailed, vivid picture of the operating room dynamics. Let's start with time. You might assume that dealing with video screens, cords, and camera fog takes longer to set up and execute.
I certainly would think so. Technology always adds a few seconds.
You'd think. But the overall time to successful intubation measured from the moment the blade entered the mouth to the first positive capnography wave was remarkably similar across all three groups.
Oh, really?
Yeah, hovering right around 72 to 74 seconds. The video camera isn't slowing anyone down.
Well, that's good to know. And from a physiological safety standpoint, the numbers are incredibly reassuring, too.
Yes, they are.
Desaturation below 90% was very uncommon. We are talking about rates of, roughly 1.7 to 1.9%. And those were statistically indistinguishable across all three arms.
Right. No real difference there.
But let's remind the listener why that is. These are well pre-oxygenated surgical patients. They have been breathing 100% oxygen for several minutes before they are paralyzed.
Which is T.
Their lungs are full of a massive oxygen reserve, which we call functional residual capacity. They can safely tolerate a minute or two of apnea without their oxygen saturation dropping at all.
Right. So the lack of desaturations isn't necessarily proof that the blades are equally safe. It's just proof that the patients are incredibly stable to begin with.
Exactly.
Where we see the real divergence in the data is in what I would call the procedural friction metrics.
I like that term, procedural friction.
Yeah, these are the rescue behaviors that happen when an airway doesn't go smoothly, even if the patient hasn't desaturated yet. Look at intermittent ventilation.
Oh, this is a huge one. Intermittent ventilation is when the clinician is struggling, realizing the intubation is taking way too long, and has to physically pull the blade out of the mouth, grab the bag valve mask, and manually ventilate the patient to restore their oxygen levels before trying again.
It's stressful.
It completely breaks your momentum. It ruins the sterile field. It ramps up the stress in the room. And honestly, it introduces air into the stomach, which increases the risk of aspiration.
Exactly.
Yeah.
And the trial showed that intermittent ventilation occurred in 11.8% of the direct laryngoscopy group.
Okay.
But it happened in only about 4% of patients in either of the video laryngoscopy groups.
Wow. 11.8% versus roughly 4%.
That is a massive difference.
It really is.
It clearly indicates that direct laryngoscopy attempts were taking long enough or were difficult enough that the anesthesiologist felt compelled to stop and rescue the patient's physiology.
Another brilliant metric of friction they measured was operator switching.
Oh, the ego metric.
Exactly. How often did the first anesthesiologist struggle so much that they had to tap out and hand the blade over to a colleague?
Nobody likes doing that.
Nobody. This was significantly more common when using direct laryngoscopy. It happened in nearly 5% of cases, compared to roughly 2% with video. So the video screen is clearly keeping the primary operator in the driver's seat longer.
We also have subjective data to back that up, too.
Oh!
The anesthesiologists were asked to rate the overall ease of the intubation on a scale of 0 to 10. Consistently, across the board, they rated video laryngoscopy as fundamentally easier than direct laryngoscopy.
Not surprising, but good to have it quantified.
Right. But I think the most fascinating, purely practical finding is what happens when things actually go wrong.
Let's talk about that.
Because 87.6% success still means over 12% failure, right?
Yeah.
How did the different modalities perform on the subsequent rescue attempt?
If you manage airways, you know that if your first attempt fails, the psychological clock in your head starts ticking twice as fast.
Oh, the adrenaline spikes immediately.
The trial found that after a failed first attempt, subsequent successful intubation occurred significantly faster with video laryngoscopy compared to direct laryngoscopy.
Mm-hmm.
Specifically, the hyperangulated video blade facilitated much faster glottic visualization and faster subsequent success when they went back in for round 2.
Furthermore, they looked at composite airway injuries. This includes things like lip bruising, dental trauma, or, the ominous finding of fresh blood on the blade when you pull it out.
Always a terrible feeling.
Awful. When a first attempt failed, the hyperangulated video strategy actually resulted in significantly fewer of these trauma metrics compared to both direct laryngoscopy and the Macintosh-style video laryngoscopy.
That's interesting.
It strongly suggests that when you are struggling and fighting the anatomy, the hyperangulated blade might offer a physically less traumatic path to the vocal cords.
Okay, so we are piling up a lot of wins for video here. Fewer second attempts, less intermittent bagging, fewer operator switches, and less trauma on the rescue attempts.
That looks very good.
But we have to apply our skeptical check. You touched on this earlier, but I want to make it incredibly explicit for you listening. The COVALENT trial did absolutely not demonstrate reductions in major morbidity or mortality.
Say it louder for the people in the back.
Seriously. Patient-centered benefits, things that the patient actually cares about, like surviving the hospital discharge, avoiding brain injury, or staying out of the ICU, were not established here.
Right.
This is an operating room population, and the baseline rate of catastrophic, life-ending airway outcomes is thankfully very, very low.
That's entirely correct. We're talking about optimizing procedural flow here. We are talking about minimizing minor soft tissue traumas. We are not necessarily rescuing these specific elective patients from the brink of death. But as we dissect these outcomes, we have to pivot to what I think is the most fascinating, intellectually satisfying nuance in the entire data set.
I know exactly what you're talking about, and I am so excited for this.
It is a massive methodological detail that completely reframes how we interpret that impressive 87.6% success rate for the hyperangulated blade.
Yes.
And this is exactly where the invited commentary by Desmet and Lascarou becomes absolutely essential reading.
This is the absolute crux of the deep dive today. Let's talk about stylets.
Let's do it.
For anyone who might not be looking down an airway every single day, let's define what a stylet actually is.
Good idea.
A stylet is a rigid, bendable metal or plastic guide wire that you slip inside the hollow endotracheal tube before you start. An endotracheal tube is basically just floppy PVC plastic. It has a natural, gentle curve, but no real backbone.
Right, it just flocks around.
The stylet gives it shape and stiffness, allowing you to direct the tip exactly where you want it to go, kind of like steering a hockey stick. Well, the trial data revealed a stark, honestly dramatic imbalance in how often stylets were used across the 3 arms.
The numbers are staggering once you spot them in the supplementary tables.
Bit me.
In the direct laryngoscopy group, a stylet was used in just 34.9% of cases.
Okay.
In the Macintosh-style video laryngoscopy group, stylet use jumped all the way to 72.5%.
Good job.
And in the hyperangulated video laryngoscopy group, stylet use was near universal, sitting at an incredible 95.7%.
We really need to let that sink in. 34.9% in the direct group versus 95.7% in the hyperangulated group.
It's night and day.
This raises a massive fundamental question about what the COVALENT trial was actually measuring.
Exactly.
Because comparing these 3 arms based solely on the shape of the blade is a bit like testing which car performs best on a treacherous, icy road. Let's say you take a standard rear-wheel drive sedan, a front-wheel drive crossover, and a massive all-wheel drive SUV.
Okay, following the analogy.
But the SUV is the only vehicle in the race that is universally fitted with heavy-duty spiked snow chains. If the SUV absolutely dominates the race on the ice, are we testing the inherent design of the car, or are we really just testing the snow chains?
Right.
In the COVALENT trial, is that 87.6% success rate solely due to the steep angle of the hyperangulated blade in the camera? Or is it heavily driven by the fact that the tube was almost universally loaded with a rigid, shape-holding metal stylet?
That is the exact devastating critique raised by Desmet and Lascarou in their editorial.
He is brilliant.
It really is, because you have to understand the physics and the anatomy of a hyperangulated blade. The curve of that blade is so steep, designed to look up and around the back of the tongue, that you physically cannot easily direct a floppy, unstyleted PVC tube around that sharp corner and into the glottis.
It just bumps into the back of the throat.
Exactly. The camera sees the cords beautifully, but the tube just flops against the wall. So clinicians, naturally and correctly, use a rigid stylet shaped specifically to match that steep curve. Right.
But with direct laryngoscopy, many anesthesiologists are historically trained to prefer a straight-to-cuff approach without a stylet, relying on the natural, gentle curve of the tube. The editorial brilliantly points out that COVALENT did not simply compare three isolated, interchangeable pieces of plastic and metal.
Right. It's not an apples-to-apples hardware comparison.
No, it effectively compared three completely different airway management strategies.
And a strategy is a bundle of behaviors, muscle memory, and adjuncts.
Oh.
Direct laryngoscopy, largely unstyleted, relies on physically moving tissue to create a straight line of sight. That is one strategy bundle. Hyperangulated video, almost entirely reliant on a rigid stylet, using a camera to look around the corner without moving tissue, is a completely different bundle.
Right.
The trial undeniably proves that the hyperangulated strategy bundle is superior for achieving first-pass success. But we cannot isolate the camera and the curve of the blade from the stylet. They are a package deal.
And we actually have a post-hoc analysis in the study itself that supports this exact theory. Oh, I forgot about that part.
Yeah, when the investigators dug back into the data and looked only at the intubations where a stylet was used on the very first attempt across all groups, the success rates suddenly clustered much, much closer together.
Wow, so the stylet was the great equalizer.
Exactly. The trial cannot definitively answer how much of the hyperangulated advantage came from the blade's geometry versus the rigid stylet, but it demands that we view these as bundled strategies, not just isolated devices.
I love that insight. It perfectly transitions us into the broader perspective provided by Desmet and Lascarou. They didn't just critique the stylets, they contextualized this massive data set by breaking it down into several critical themes that you, the listener, need to understand before you change your practice.
The editorial is a masterclass in critical appraisal.
It really is. So theme one is the vital distinction between a procedural surrogate and a patient-centered outcome, which we touched on briefly, but we really need to hammer home.
The editorial authors aggressively emphasize that while first-pass success is incredibly objective and clinically intuitive, I mean, we all want the tube in on the first try, it ultimately remains a procedural surrogate.
Right.
Yes, repeated airway instrumentation causes swelling, bleeding, and stress. But in the routine, well-controlled perioperative anesthesia setting of this specific trial, improved first-pass success did not translate into a clear, measurable reduction in major patient-centered complications.
No one died less.
Right. No one went to the ICU less. It is a vitally important surrogate for quality, but it is not definitive proof that you are fundamentally altering long-term patient trajectories in the operating room.
Which brings us directly to theme two, and this is perhaps the most crucial clarification for our audience today. I want to explicitly state this for you. COVALENT was not an intensive care unit trial.
Very important distinction.
The editorial vigorously contrasts the controlled perioperative environment of COVALENT with the sheer terror of an emergency intubation in a critically ill patient.
The physiology is worlds apart.
Complete opposites.
In the operating room, as we discussed, your patient is fasting. They have an empty stomach. They are pre-oxygenated, hemodynamically optimized with fluids or pressors by the anesthesiologist, and they typically have a totally normal functional residual capacity in their lungs.
Right, they are primed for success.
If you miss the first attempt, you have the luxury of time. You just grab the bag, ventilate them back up to 100%, and try again.
But in the intensive care unit or the emergency department trauma bay...
Oh, it's a nightmare. Your patient might have severe acute respiratory distress syndrome, profound septic shock, a stomach full of half-digested food, and zero physiologic reserve.
Exactly. In the ICU, their functional residual capacity is often obliterated by fluid or pus in the lungs. In that setting, a second attempt does not just mean a few seconds of annoying intermittent ventilation.
No, it means profound rapid hypoxemia.
It means hemodynamic collapse. It means peri-intubation cardiac arrest. Desmet and Lascarou specifically point us to the broader evidence base, citing the device trial, which looked at critically ill patients.
Right, the stakes are so much higher there.
In the ICU, repeated attempts are far more directly associated with devastating adverse outcomes. COVALENT proves the procedural benefit of video in the calm waters of the operating room, but we have to look to different literature to fully grasp the life-or-death stakes of video laryngoscopy in the chaotic waters of the intensive care unit.
And that leads us to theme 3 in the editorial, which requires us to look very closely at the screening funnel and the potential for selection bias.
This blew my mind when I read it.
It's a staggering methodological detail that is so easy to miss if you're skimming. The investigators screened nearly 30,000 patients across these 6 hospitals.
Right.
but they only randomized about 2,500 of them.
Meaning 27,000 patients were excluded from this trial.
Yes. We have to ask why.
That is a phenomenal attrition rate.
Mhm.
One major reason is that the anesthesiologists running the trial were explicitly allowed to exclude patients if they had clinical concerns about random assignment. If an anesthesiologist looked at a patient's airway anatomy in the pre-op area and thought, I absolutely need video laryngoscopy for this airway, it looks awful, I cannot risk them being randomly assigned to a direct metal blade, that patient was pulled from the study entirely.
Which is completely ethical for patient safety, of course.
Oh, absolutely ethical. But what does that massive exclusion rate actually mean for the data we are looking at?
Well, the editorial authors suggest this exclusion rate might actually reflect how deeply video laryngoscopy is already entrenched in modern clinical practice.
It's already the standard.
Exactly. If everyday clinicians are actively refusing to randomize suspected difficult airways because they feel video is the undisputed standard of care for a tough case, it shows a massive cultural shift.
Yes.
It means that people actually enrolled in this trial were the ones the clinicians thought would be relatively easy. Furthermore, we have to look at the Malampati scores of the patients who did get enrolled.
Let's do a quick refresher on that for anyone listening who doesn't score airways every day. The Malampati score is a visual assessment of the airway we do before intubation to predict difficulty.
Right, the open your mouth and say, test.
Exactly. You have the patient open their mouth and stick out their tongue. A Malampati class 1 means you see the entire uvula and tonsillar pillars wide open, easy airway.
A dream airway.
A dream. But a Malampati class 4 means you only see the hard palate. You can't see the uvula at all. It's a notoriously difficult view.
Right, and roughly 19% of the randomized cohort in COVALENT had a Malampati class of 3 or 4.
Okay, so a decent chunk of predicted difficult airways slipped into the trial.
Yes. Clinicians often preferentially select video laryngoscopy for Malampati 3 or 4 airways as a first-line defense in the real world. By including these specific, historically difficult patients in the randomization and potentially forcing them into the direct laryngoscopy arm, it is entirely possible the trial artificially amplified the intervention effect.
Wait, explain that. How does it amplify it?
In other words, if you force direct laryngoscopy on patients who would normally get video because they look physically difficult to intubate, the direct group is naturally going to perform worse, making the video groups look that much better by comparison.
Ah, I see.
It is a subtle but absolutely vital point regarding who exactly was in this study and how that impacts the final percentages.
It's all about who was allowed in the room. Now, theme 4 from the editorial addresses the limits of generalizability. We spent time earlier praising this trial for being pragmatic by allowing multiple manufacturers, which is true.
It is true.
However, when you dig into the supplementary data, it shows that Storr's CMAC devices heavily predominated the trial, representing over 60% of all the video laryngoscope usage.
Yeah, it wasn't an even split by any means.
Right. While having multiple devices improves external validity compared to a single device trial, the editorial cautions us against blindly generalizing these results to every single video device on the market. Specifically, they point out channeled video devices, where the tube slides down a plastic groove attached to the blade, which have completely different handling characteristics and were not deeply represented in this data.
And finally, theme 5 raises the inevitable, slightly uncomfortable question of economics.
It always comes down to money.
Always. If video laryngoscopy continues to cement itself as the universal standard of care for tens of millions of routine elective intubations every single year, is it actually cost-effective?
I mean, video blades are not cheap.
No, they aren't. First-pass success goes up? Yes. That is great. But does the reduction in a few seconds of intermittent bag mask ventilation or the slight drop in having to switch operators actually justify the massive upfront equipment costs of buying thousands of monitors, plus the ongoing daily expense of disposable blades and plastic sheets at a massive population scale?
That is the million-dollar question for hospital administration. If the primary benefit in the operating room is procedural smoothness and less lip bruising, rather than preventing catastrophic mortality, you can bet that administrators will heavily scrutinize the economic case.
Oh, absolutely.
Future cost-effectiveness studies will have to account for the price of reusable versus disposable blades, the sheer daily volume of the operating room, and the cost of downstream complications. It is an unresolved tension between clinical preference because, let's be honest, we all love the screen and harsh economic reality.
So after dissecting this massive stack of data, breaking down the statistics, unpacking the stylet nuance, and reviewing the editorial context, I have to ask you directly.
Okay, hit me.
Does the covalent trial finally settle the video versus direct debate in the operating room once and for all?
I would deliver the verdict this way. COVALENT substantially, heavily strengthens the case for video laryngoscopy as the routine, default, first-line strategy in the operating room. It is a landmark piece of evidence for that transition. It proves that the camera helps you succeed faster and with less friction. However, it absolutely falls short of proving that all video devices are perfectly equivalent.
Right.
It does not prove that hyperangulated blades are the perfect, infallible tool for every single patient anatomy. And crucially, it does not prove that simply improving first-pass success in an elective stable surgery equates to better long-term patient survival.
I agree completely. Let's summarize the strengths that give this trial its weight.
Let's do it.
It is a beautifully large, randomized sample. It utilizes a multi-center, highly pragmatic approach with real-world clinicians who are just doing their jobs, not putting on a show for a highly controlled artificial trial.
Yep.
It tested 3 simultaneous treatment strategies, and it gave us the exceptionally rare head-to-head comparison of Macintosh-style video versus hyperangulated video. That alone is a massive contribution to the airway literature.
But we absolutely must balance those strengths by scrutinizing the limitations we've uncovered. First, the unblinded design. You cannot blind a clinician to what device they are holding in their hand. They know if they're looking at a screen or down a metal tube, so performance bias is inherently present. Second, as we discussed at length, the massive stylet imbalance makes this a comparison of bundled strategies, not just a clean, isolated test of device hardware.
We also have to look closely at the crossover data. 41 patients who were initially assigned to direct laryngoscopy actually crossed over.
What does that tell you?
Well, it means the clinician completely abandoned the study protocol and switched to video laryngoscopy, either right before the attempt or shortly after opening the mouth and assessing the patient.
They chickened out.
Basically. This suggests a very real, palpable, real-time clinician hesitation with direct laryngoscopy when push comes to shove. And, of course, the highly selective randomization funnel, 30,000 screens just to get 2,500 enrolled, means we are looking at a very specific, heavily curated slice of the surgical population.
And we must continually return to the primary endpoint. It is procedural. While vital for tracking airway management quality, a surrogate endpoint inherently limits how aggressively we can claim patient-centered victories.
This brings us directly to the bedside relevance for you, the intensive care unit listener.
Yes, let's bring it back to the ICU.
Many of you listening are intensivists, emergency physicians, respiratory therapists, and critical care nurses. If video laryngoscopy is steadily cementing its place as the default first-line approach in both routine anesthesia and in emergency airways, I think we have to admit that the old, fiery debate of video versus direct is basically dying, if not already dead.
It's over. COVALENT, despite being a controlled operating room trial, adds another heavy, undeniable brick to the wall of evidence favoring video. For the critical care clinician, the question is no longer, should I use video?
No, we've moved past that.
The evidence from massive trials like DeVice has already answered that for the ICU. The new frontier requires us to move past that basic question and ask much sharper, more clinically useful questions at the bedside.
Exactly. The new questions are highly specific, like, which specific video blade is best for this specific patient in front of me right now?
Right.
Do they have restricted mouth opening from a trauma? Do they have a massive neck circumference and an anterior airway? What is the optimal stylet or bougie strategy to pair with that specific blade?
Because as we've learned today, a hyperangulated blade without a rigid stylet is essentially useless.
Just floppy plastic.
Exactly. A Macintosh video blade paired with a flexible bougie might be the absolute perfect strategy for one patient, but terrible for another.
We also need to ask how operator experience dictates device choice. Does a terrified first-year resident perform better with a channeled device where the tube goes exactly where the camera points?
Probably.
Does a 20-year attending expert need the hyperangulated blade for a truly awful anterior airway, but prefer the Macintosh video for a standard case?
These are the real questions.
And as we mentioned, how do we justify these staggering costs at scale for our departments? Finally, what patient-centered outcomes should we be measuring in future trials? We need to look way beyond first-pass success.
Absolutely.
We need to look at ventilator-associated pneumonia rates, long-term tracheal stenosis from cuff trauma, and true measurable morbidity.
As we wrap up this deep dive, I want to distill this massive trial, the complex statistics, and the editorial context into 3 concise, highly memorable takeaways that you can carry straight into your next clinical shift.
Sounds good.
Number 1, the COVALENT trial provides strong, randomized, pragmatic evidence that video laryngoscopy significantly improved first-pass success compared to traditional direct laryngoscopy during routine perioperative intubations.
Number 2, while hyperangulated video laryngoscopy performed the best statistically, the massive, undeniable imbalance in stylet use across the groups means this was fundamentally a comparison of airway strategies, not just isolated blade geometry. You simply cannot separate the hyperangulated blade from the rigid metal stylet that makes it physically work.
And number 3, the next step for airway management is no longer trying to prove that a video screen is helpful. We know it is. The goal now is optimizing the full, bundled video laryngoscopy strategy, choosing the right blade, pairing it with the right stylet or bougie, and matching it to the operator's technique, and proving that these choices yield benefits that actually matter to the patient's recovery, not just to the proceduralist holding the scope.
We opened today by talking about the video screen being the absolute first thing you turn on in a crisis. This data tells us that even when there is no crisis, even in the serene calm of the elective operating room, turning on that screen and utilizing a bundled video strategy is very likely the safest, most efficient path to securing the airway.
But it demands that we actually know exactly how to use the tools we are picking up.
It's not just about turning on the camera, it's about understanding the entire biomechanical approach.
I want to thank you for joining us on this deep dive. If you found this breakdown of the COVALENT trial helpful for your clinical practice, we warmly invite you to follow PRISM Rounds on Apple Podcasts, Spotify, or YouTube. We will continue bringing you deep dives into the absolute newest pulmonary, critical care, sleep, and airway literature. Until next time, keep questioning the evidence and stay sharp at the bedside.
Thanks for spending your time with PRISM Rounds. If this episode was useful, please like, follow, or subscribe, and share it with a colleague. Leave a comment with your bedside takeaway, a question, or a paper you'd like covered next. Your feedback helps shape future episodes. Thanks again for listening. Educational use only, not medical advice.